Yeah. Good evening, everyone. I'm seeing that people are still joining in. We are on time, actually.
There's 2 minutes more.
Yeah. 2 minutes more. The facilitator or the resource person for today has joined in, Ms. Mahashweta Bhattacharya. Then, Mahashweta, here we have the course coordinator and the faculty of St. Agnes Institute, Dr. Kavya Sri KV.
In Kelsa?
Okay.
She is online. She is the one who has facilitated in arranging the students from your institute.
Okay.
Yeah, and we also have Dr. Shashi Bhushan from CIP who has joined in.
Okay.
And Ms. Sushita from Mumbai has joined in. She is a renowned columnist. She writes for some lifestyle magazines, including Femina. She is a psychologist by profession. She is having her practice in Mumbai.
Okay.
ಓಕೆ ಸೊ ಜಗಳ ಆಮೇಲೆ ಇವಾಗ ಸ್ವಲ್ಪ ಗಾಬರಿ ಹೆದರಿಕೆ ಈ ತರ ನಿದ್ದೆ ಬರಲ್ಲ ಯಾವಾಗಿಂದ
Just like we have 33 people who have already joined in.
Yeah.
Daily.
So can we begin?
One quarter, okay.
Yeah, I think we can begin.
ಯಾವಾಗಿಂದ
ಎಲ್ಲ ಊರಿಗೆ ಹೋದ ಒಂದು 3-4 ಡೇಸ್ ಊರಲ್ಲಿ ಇರ್ತೀರಿ ಯಾವ ಊರಿಗೆ ಹೋದ್ರಿ ಅವಾಗೆಲ್ಲ ಜಾಲಿಯಾಗಿ ಹಿಂಗೆ ಕೂತಿರ್ತಿ ಅದು ಜಾಸ್ತಿ ತಿರ್ತಿರ್ತಿ ಜಾಸ್ತಿ ಆಗುತ್ತೆ
ಎಷ್ಟು
ಒಂದೂವರೆ ಕ್ವಾರ್ಟರ್ ಒಂದು ಕ್ವಾರ್ಟರ್ಗೆ 90 ಎಕ್ಸ್ಟ್ರಾ ಆಗುತ್ತೆ
ಟೋಟಲ್ ಎಷ್ಟು
ಊರಿಗೆ ಹೋದಾಗ ಮಧ್ಯಾಹ್ನ ಒಂದು ಕ್ವಾರ್ಟರ್ ಸಾಯಂಕಾಲ ಒಂದು ಕ್ವಾರ್ಟರ್ ಆಗ್ತದೆ
2 ಕ್ವಾರ್ಟರ್ ಅಷ್ಟೇ
ಊರಿಗೆ ಹೋದ ಮಾತ್ರ
2 ಕ್ವಾರ್ಟರ್ ಅಷ್ಟೇ
ಅದೇ ಬೆಂಗಳೂರು ಹೋಗಿದ್ರೆ ಒಂದೇ ಕ್ವಾರ್ಟರ್ ಡ್ಯೂಟಿ ಎಲ್ಲ ಮುಗಿದು ಮನೆಗೆ ಹೋಗಿ ಒಂದು ಕ್ವಾರ್ಟರ್ ಕುಡಿತಿದ್ದು ಊಟ ಮಾಡ್ಕೊಂಡು ಚೆನ್ನಾಗಿದೆ ಏನು ಟೆನ್ಷನ್ ಆಗಿ ಈಗ 4-5 ದಿವಸದಿಂದ ಸ್ವಲ್ಪ ಇದು ಈ ಥರ
ಸೇಕಿದೆಯಾ
ಸ್ವಲ್ಪ ಸೇಕಿದೆ ನಿದ್ದೆ ಬರುತ್ತೆ ಹೊರಗೆ ನಿದ್ದೆ ಬಂದಿದೆ ಅದಂತ ಕೌನ್ಸಿ ಬೀಳುತ್ತೆ ಸ್ವಲ್ಪ ರೇಟಿಂಗ್ ಕನ್ಸುತ್ತಾರೆ ಇರುತ್ತೆ ನನಗೆ ಮಲಗಿರ್ತೀನಿ ಏನು ಅದರ ಮಧ್ಯೆ ಎಲ್ಲ ಎದ್ದಾಡೋದು ಮಲಗದೆ ಹೆಚ್ಚಿಗೆ
ಹೆದರಿಕೆ ಈ ತರ
ಸ್ವಲ್ಪ ಧೈರ್ಯ ಇದೆ ನಾನು ಮಲಗದೆ ಹೆಚ್ಚಿಗೆ 11:30
Yeah, Mahashweta, can you start?
Yeah.
Sarishri ma'am, can we start?
ಮ್ಯಾಚ್ ನೋಡ್ತೀವಿ ಕ್ರಿಕೆಟ್ ನೋಡ್ತೀವಲ್ಲ ಅದೊಂದು ಹ್ಯಾಬಿಟ್ ಇದೆ ಮ್ಯಾಚ್ ಅದು ಸ್ವಲ್ಪ ಅದು ಟೆನ್ಷನ್ ಅದು ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತದೆ
Good evening, everyone. Greetings on behalf of Arka Healthcare, on behalf of Health Diary, Dr. Shashi Bhushan, and also from Dr. Kavya Sri and Ms. Mahashweta. I hope you are all doing great. Today, as we all know, that we are gathering here for the presentation for the workshop on the psychological management of OCD. For today, we have a very good resource person with whom I have worked also, and it has been really pleasure working with her. She is Ms. Mahashweta, who is currently pursuing her PhD at the Department of Clinical Psychology, working in the area of neuropsychology, cognitive training, and integrative psychotherapy. and is associated with the OCD clinic in the premier institute that is
ಇವಾಗ
in Bangalore.
ಗಾಬರಿ ಹೆದರಿಕೆ
She is a
ತುಂಬಾ
licensed
ನೆಗೆಟಿವ್
clinical
ಥಾಟ್ಸ್
psychologist under Rehabilitation
ಸೇಕ್ ಇದೆಯಾ
Council of India. She has done her MSc in clinical psychology and forensic psychology from Calcutta University. She was a gold medalist during her master's, followed by being the topper in the entrance for MPhil in clinical psychology in PIT Ranchi. She completed her MPhil in PIT Ranchi in the year 2018, where again she was the topper. She has received Best Student Award felicitated by the then Governor of the state of Jharkhand. She has also presented and has received awards for the best paper in several national and international conferences. And she also has delivered lectures at both PG and UG level for clinical psychology at various institutes in multiple states. Okay, yeah. So the list will go on and on if I go on speaking. I guess like I will cut short the introduction for Ms. Mahashweta. Yeah, so I guess Mahashweta, I guess you can take over the presentation from here on, and we will be like pleased to get benefited by your presentation today.
Yeah.
I welcome you on behalf of everyone. Thank you.
Yeah. Thank you, Dr. Manu. That was like a very big introduction. I don't know how much I deserve that big. And I am not sure of all the kind of audience here. Some are actually more experienced than me, I guess, and some are still doing their PG. So I have tried to cut short my presentation so that it's suitable for both kinds of audience. And I hope I can generate a little more understanding into the psychological management of OCD. So yeah, I would and thank Dr. Manu for arranging this workshop. So usually in a physical type of a workshop where we can interact with the audience, it's little easier for me. I have done that before, and somehow I can ask questions in between, but here it will be more of kind of a presentation. So just bear with that. I will try to make it as interesting and as involving as I can. So I'll present my screen, share my screen. Yeah.
4 years back.
So
Same
yeah. So can you see the screen?
Yes, yes.
Yeah.
Yeah.
So basically the focus of this topic is psychotherapy in OCD and basically the psychological management in OCD. However, instead of jumping directly to that, I would give a little bit introduction about the disorder itself, because there is a varied audience over here, and as well as the assessment a bit of how we assess patients when they come, and moving on to the therapy and specifically the more advancements in the psychological management that has happened over the decades. So coming to what is OCD, as we all know, OCD is a common mental illness and it is characterized by two things. One is obsessions and compulsions, or commonly both. So obsessions are basically some repetitive, persistent, intrusive and unwanted thoughts, images or impulses, and compulsions are behaviors, rituals or mental acts which are again repetitive. A person is driven to perform them, and often they serve act of neutralizing the obsessions. So coming to how common is OCD. Now, the point prevalence of OCD is around 1 to 2% across children and adult. Like, it's quite common. Lifetime prevalence is approximately 2%. What is important is that according to WHO, OCD is the sixth most disabling psychiatric disorder, and less than 50% in West seek treatment, and India we know of very few numbers. Now it occurs across all age groups. 65% develop this illness prior to 25 years of age, and some as early as 5 years, and less than 15% develop their illness after 35 years. It's equally prevalent in both sexes, and more, however, in when we are talking about early onset, especially in childhood or adolescence, we see that it is more common in boys. Now, a little bit about the classification of where it falls in OCD. Now, it has evolved over the time. Previously, in the versions of DSM, it was included in under anxiety disorders. Now, both in ICD-11, which is the latest one, as well as in DSM-5, OCD has its separate place. Like OCD is more known as obsessive compulsive and related disorders. So in DSM-5, under it falls obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation disorder. And in ICD-11, the ones which are extra are olfactory reference disorder, hypochondriasis, and some body-focused repetitive behavior disorders, like I said, trichotillomania, excoriation. So this is the current classification of OCD right now in the latest systems. So little bit about the phenomenology and clinical assessment, as I said, I will discuss. So I would like to start the phenomenology with 2 case examples, because that will be the best way to discuss later how are we, making them fall into the categories. So first example, Anil is a 20-year-old man who is a trainee hairdresser in the local town. He has always loved his job and is enthusiastic and eager to learn. Anil's obsessive compulsive trait started when a lady arrived at a salon one day to have her hair styled. On examining the scalp with his bare hands, Anil noted that lady had some lesions in her scalp that were oozing. This frightened Anil, as he feared that these lesions were contagious. He washed his hands but was not convinced that he had done this properly. Following this episode, Anil began to wash his hands on a regular basis, even after touching the equipment in the saloon that his colleagues were using. This obsession spilled over into his home life. He began to develop a certain ritual which he followed religiously. He started to bathe about 3 times a day. He started getting up earlier each day so that his ritual can be followed. And if he did not follow his ritual specifically, he would need to start the ritual again from the beginning. Anil's work attendance began to fade, and at times he could not even leave the house because of his obsession. Anil needed to be admitted to a psychiatric unit for the treatment. So this is one type of a case example that we see. And another which I have come across. Ria is a 21-year-old graduate studying accountancy who has been distressed for the past few weeks by some disturbing thoughts. She has thoughts of slapping her friends for no reason when they study together, and also has mental images of indulging in sexual acts. Now, she finds these thoughts and images to be repulsive, disturbing, but they continue to be intrusive and difficult to resist. She's even more distressed when she goes for her regular prayers. She will have sudden impulses to blaspheme the name of God, and she is afraid that she might lose control one day and shout blasphemies in the public. So, coming to the major question is that OCD phenomenology has been studied under 2 headings. So we come to the form of OCD, which refers to the structures of the phenomena, and content, which refers to the meaning reflected by it. So in form, we discuss basically what type of form the intrusive thought comes in. So it can be in the form of doubt. It can be obsessive thinking. Sometimes thinking takes a form of obsessive ruminations. obsessive fear, impulse, image. And in terms of the content, it can be the most common one is dirt and contamination. Then we have aggression. Then some things which are related to inanimate and impersonal things, sexual obsessions, religious obsessions, and various other miscellaneous categories. Coming to compulsions very broadly in terms of form can be divided into two. One is the overt compulsions, which we can see that they are doing, and covert is more of which happens internally, as in the mental compulsions. So basically, content is washing, checking, counting, repeating, arranging miscellaneous content. So washing is like the most common one. Now, coming to these two examples, so the first one we see that was more related to dirt, contamination, and getting some disease, and so she had mostly washing compulsions. And the second one had quite many. It had aggressive obsessions, sexual obsessions, and religious blasphemous obsessions. And there was mostly she was doing some regular prayers and mostly mental compulsions. So, coming to the clinical assessment of OCD. So, is my screen visible?
Yes, yes.
Yeah,
it's very much clear.
Yeah, thank you. So, coming to the clinical assessment of OCD, so the most common and I would say the most useful assessment that is used in OCD till now has been the Yale-Brown Obsessive Compulsive Scale, both the checklist and the severity scale. Like, it gives a very comprehensive view and is very useful to do Y-box. It's known as the Y-box before starting therapy, or even for treating the patient. And there are other inventories as well: obsessive compulsive inventory, Maudsley obsessive compulsive inventory, Padua inventory. Like at Nimhans here, we are doing always Y-box for every patient that comes to the OCD clinic. So I would like to show one screen of how Y-box goes, because it is very useful for starting therapy, because sometimes the patients do have a lot of symptoms, and it's always useful, we miss them in a clinical interview, to have this checklist and as well as the severity, so that we can track the changes over a period of time. So this is how Y-box goes. One thing which is very important, another that in Y-box is the insight and avoidance. That has to be noted. Most of the time we tend to miss that, but insight is very important in OCD, because some patients do have good insight, very excellent insight. They readily acknowledge the absurdity and the excessiveness of the thoughts. However, some people actually have very poor insight, and some of them actually have comorbidity with psychosis. So here, we have to treat them accordingly, because always with poor insight, therapy in the traditional way is not possible, and is also same for pharmacotherapy. Okay, I will move on to the next thing. Before going into psychological management, another thing that is very important is the comorbidity. OCD often coexists with other psychiatric illnesses, and most commonly with depression, phobia, GAD, tics disorder, schizophrenia, alcohol, and drug addiction. Why is the recognition of these comorbidity very important? Because if not treated, OCD by itself may not respond adequately to the treatment, and overall it increases the suffering already in distressed OCD patients, and causes more disability. Another thing that is common is that depression can develop secondary to the presentation of OCD, sometimes because people are so severe, having severe presentation, and so debilitating in nature their OCD is, that they do develop depression and low mood, suicidal thoughts also. So we have to consider all these comorbid conditions that can happen before we go on for treating the patient. Now coming to treatment. So treatment, the first question that comes in mind is medicine or therapy. So I know many people say that, oh, I don't require medicine, therapy will be fine for me. Or many people will say that I will only take medicine, it will magically work, and therapy is not at all required. However, evidence-based studies and everything suggests that both are equally effective, and sometimes, most of the times actually, both in combination is the best thing. So common questions that arrive while we think about treatment is, what is the best first line treatment? What will be the most fast, most effective, and most long lasting? Right. So pharmacotherapy is not my area. I will not go into it. However, we just need to know what is done. So there is a class of drugs called the serotonin reuptake inhibitors that has been found effective, and it is most commonly used. SRIs are on the screen, and they basically increase the amount of serotonin in the brain. So however, we see that even though medicine is very effective, like in almost 60% of patients it works, however, a significant percentage of patients, like 40%, who do not respond to this single drug therapy. So, and we see that if behavior therapy is used as an adjunct, this figure comes down to 20-30%. So there is a vast difference when we use behavior therapy as well. So going on to the psychological management. So here I will talk about both the existing therapies or the management line in OCD, as well as some of the advances and current trends that are coming up in the recent years. So moving on to the most famous therapy for OCD, I'm sure many of you are already knowing it or might have practiced it. It's called the exposure and response prevention therapy, and it is like the first line interventions among the empirically advocated non-pharmacological treatments for OCD. And I would say that if ERP is done properly, like maximum patients improve, but it has to be done properly. That's the thing. So response rates are as high as 85% in patients who receive a complete course of the ERP sessions, and it basically involves prolonged exposure in vivo or in vitro imaginary to obsessive stimuli without engaging in compulsions. So the basic tenor in which the therapy of ERP is based is habituation. That I will be exposed to the triggers or the stimuli that cause the obsessive thoughts. However, I will not engage in the compulsions. Now, obsessions and compulsions are very interestingly related. So obsessions directly do not lead to compulsions. There's something that comes in between, that is anxiety and distress. So when we are having the anxiety, obsessive thoughts or images, whatever it is in form, we have experienced a certain amount of anxiety, and the anxiety eventually rises. And what happens is that to bring down the anxiety, we engage in certain compulsions. So in a typical OCD patient, what happens, we can see the graph over here. So when the person is engaging in any kind of compulsion or ritualization, the anxiety drops very quickly. Okay, it reduces, and it doesn't stay for much long. So it becomes a habit to do this. So whenever I get a little anxiety, I will do the compulsion and it will drop. However, it is seen that if we do not perform any compulsions or rituals, the course of anxiety usually it reduces on its own. And so the basic tenor of ERP is that I will expose the person to the obsessive stimuli, and the person will experience anxiety, and the person has to ride the wave of anxiety basically and not give in to compulsions. Okay, so what happens with time? The peak of the anxiety also comes down. That is, the first time the amount of anxiety, the peak of anxiety that the person received in the first exposure will come down eventually, and the person will get habituated. So, giving a very simple example is that if I am having an obsession regarding dirt and contamination, so I will be exposed to the stimuli. Suppose I am exposed to dog feces, and seeing that causes me distress, and I go and wash my hands. So what will I do? My therapist will do is, my therapist will start taking like, there is another procedure where we will do a gradual exposure. So basically I will be exposed to situations which are triggering this obsessive thoughts, like I will be exposed to dog feces, and then I will not be allowed to wash hands, and I have to experience the anxiety totally. And this will occur repeatedly with different stimuli. So here is an example of the self-monitoring form, and this can be done with the therapist also. So basically, it is to recognize in ERP all the different situations that evokes a distress or an urge to, do compulsions, and these are called the SUDs. The full form of SUD is subjective unit of distress scale, and we rate each of them between 0 to 100. And we also describe the ritual. So this sheet will help us to develop our plan for the exposure. And while doing the exposure, we will also note down some of these things like time spent, difficulties. It's not that easy. It's very difficult for an OCD patient to experience that anxiety and tolerate it. So that's why usually we will go in a very gradual manner. So now, coming to cognitive behavior therapy for OCD. Now, ERP and CBT for OCD is not exactly different that many people actually try to say. ERP is basically the behavioral component of CBT, and cognitive interventions do come in ERP as well and go side by side with the sessions. So basically, what happens when we are saying it is a cognitive behavior therapy is that there are behavioral component, the exposure will be done, and we will also deal in session with various biases that the patients have regarding their obsessive thoughts. There are many cognitive distortions in OCD, which I'll come to, which will be dealt and restructured in the cognitive behavior therapy sessions. So, and sometimes ERP is not used, mainly cognitive, we call it cognitive therapy, when, where there is primarily the obsessions are the only thing that is there, and compulsive hoarders and primary obsessive slowness, people with pure obsessions without compulsions, and poor insight OCD as well. But however, I would like to say that even though a person appears to be purely obsessional, if you try to interview the person properly, many a times we will get some or the other mental compulsions that the person is doing, in terms of maybe try to neutralize the thought obsession in some way or the other, thinking about something else, which doesn't come out usually if you don't tease out properly. So I will just summarize the basic steps in ERP CBT for OCD. First is we give a good psychoeducation in OCD. Never skip the psychoeducation part, because we have seen patients actually improve only with psychoeducation when they come to know about how this anxiety curve happens and about habituation. Then there is the second step is the stimulus hierarchy is created. We rank these all the triggers according to the degree of distress, And then the exposure itself, the individual has to confront the trigger, starting with, we start usually, it's a gradual exposure. We start usually with a less anxiety provoking stimuli, like, with 40% or 30%, and go above with, slowly we go to 80-90% distress arousing stimuli. Third, cognitive strategies come in to the highlight. They confront their irrational thoughts. And two very common biases that happen in OCD are overestimating and over responsibility for an event. That is there. And addition, some strategies like constructive self-talk is also added to enhance motivation and engagement in treatment procedures, because this is very important, because ERP is after all difficult for the patient to do, and there are a lot of people who drop out during the sessions. So coming to, I said I will discuss some of the like the advances that have happened over the time in ERP and CBT. So this has happened in terms of basically two things. One is the delivery of CBT. That is, some programs, like recently a very famous program that came out in 2019-18 time was the Bergen 4-day program, treatment of ERP. It was intensive exposure sessions with where patients were admitted, and in 4 days they were giving almost of 10 to 12 hours of exposures, and one-to-one therapist and patient combinations were there. Another thing that comes in is the gradual versus variable exposure intensity in terms of the hierarchy. I'll discuss this because it's important. And the cognitive process mechanisms have also been advanced. They have theoretically they have seen that inhibitory learning is actually the mechanism that works instead of habituation, and there's something called intolerance to ambiguity and uncertainty that has a role to play. So what is this gradual versus variable exposure? So we see that in traditional ERP is conducted in a gradual approach in which stimuli are rank ordered, as I said. However, 14 to 31% are non-responders we see, and 50 to 60% experience partial symptoms relapse. So there is reservation against traditional CRP. Traditional ERP. And one is that there is an anticipatory anxiety towards the higher items in the hierarchy. So if I know that I am in, okay, so this is my list, there is, in the bottom of the list, there will be maybe the door handles and the taps, and then there is garbage, and there is actually going into the toilet, which is at the very higher in the hierarchy. So the person will obviously have an anticipatory anxiety to move towards very higher items in the hierarchy, and they might rely on habituation as an escape from anxiety. I will do this exposure because I know my anxiety will come down. So what is variable exposure technique? It's a better alternative. It's basically based on the extinction sizes and remembers what is happening. And the most important thing is that variable exposure resembles real world scenarios, because in the real world, I'm not getting exposed to stimuli in a gradual manner. It's like combined. So coming to the newer, I'll not go very detailed into the theoretical part. So there is as I said, the earlier model, the concept of habituation is not necessary. Like, it's saying that it's more of inhibitory learning. That is, the fearful associations are not unlearned or modified during exposure, but instead these associations are forced to compete with newly acquired safety associations, that germs do not necessarily lead to illness. Now, intolerance to anxiety is uncertainty is another new concept about OCD that believes about the necessity of being certain about the capacity to cope with unpredictable change. And these sometimes underlie maybe the driving force for worry, obsessions, compulsions, hypervigilance. So coming to more newer therapies, So we all know that in psychotherapy there has been an evolution in recent years. The terms new wave, third wave, new generation behavioral therapies have come increasingly in the literature. So this has been applied in OCD as well, and we will see what is happening. So we see those. There was the first wave was basically only behavior therapy. Second wave was cognitive behavior therapy. Third wave is what we know as these. We can crux it into all the 5 concepts like acceptance, mindfulness, metacognition. Basically, these focus on the relationship with one's inner experiences and not the content of the experience. And it's dependent on psychological, it's a concept of psychological flexibility, that we distance from the thought without attaching much importance to it. Now, so these are the new wave behavior therapies that have come into focus and has been used in OCD. One is acceptance and commitment therapy, mindfulness based commitment therapy. It's actually there's a mistake. It should be cognitive therapy, metacognitive therapy, and danger ideation reduction therapy, DIRT. So how is this used in OCD? Coming to acceptance and commitment therapy, so it is based on a theory called the relational frame theory, in which we use language to try and modify certain thoughts. So the primary source of our problems, they say, is psychological inflexibility, that is the narrowing of our options for behaving, and there is a general tendency to avoid, escape, and control. So in OCD, how is it done? Is basically there is acceptance of unwanted thoughts whose occurrence or disappearance is not under one control. So it's actually going opposite to what we are doing in ERP. Maybe it's just accepting the thoughts as they are and not doing anything. And commitment is action towards living a valued life, putting value on other things that matter in our life. So therapy is conducted over 8 sessions usually. So in specifically, how do we integrate ACT into OCD? So first we go by examining the success of previous attempts to regulate obsessions and the how useful has this previous attempt been for the individual. We use various exercises and metaphors to illustrate the futility of resistant fighting or trying to control unwanted internal experiences. There is a discussion of how obsessions cannot be controlled, accepting obsessions and the associated anxiety as a part of illness, and training in psychological diffusion, which is also a very core concept of ACT, that is perceiving inner experiences on only thoughts, feelings, and bodily sensations and nothing more, so that the person does not identify himself with the experiences, can distance oneself. So if a person is having a sexual obsession, we will not say it is the person is trained to recognize it's not him is reflected through his sexual obsessions. These are just isolated experience of thoughts that are coming and going. Now, so we will train the person in values that are important, and you will increase behavioral commitments to engage in value-based activities. So coming to the efficacy of ACT in OCD, so it has been reported that studies have shown there are reductions in symptoms of OCD, depression, anxiety, especially the associated conditions like anxiety and depression, and they have been maintained at 3 to 6 months follow-up, and there has been reduced frequency of obsessions in children as well. So practical consideration is that there is no significant difference when it was found that ACT was compared with ERP and cognitive therapy. And another problem was the studies used in ACT and OCD largely involved mostly the non-clinical subjects, that is people who had subclinical OCD probably. Coming to the next famous therapy that this is being increasingly adopted, that is called the mindfulness based cognitive therapy. So as you all know, mindfulness is like paying attention in a particular way on purpose in the present moment and non-judgmentally. Now MBCT has been called mindfulness integrated CBT. So we mix components of CBT and introduce some components of mindfulness in the therapy. So cognitive restructuring is used, and there is a common practice of a mindfulness training in an 8-week format. So patients are basically taught to observe every arising thought, label it. Many times people don't label their thoughts and try not to judge it, accept it, and refrain from acting on it compulsively. So this some of the ways in which adapting MBCT for OCD again should be begin with psychoeducation, then developing awareness of the this is the practice of being mode, commonly known in MBCT, where we develop awareness and acceptance of the obsessions that keep on having the thoughts. This is an important step. There is self friendly attitude towards self compassion. Like people try when they have these lot of distress and negative self talk, and they demean themselves, feel guilty, so they have to develop this friendly attitudes towards self, for self compassion. Then we combine it with the exposure to triggers and the use of mindfulness instead of compulsions. Like they are exposed to the triggers and they will practice some kind of mindfulness instead of giving in to the compulsions. There's attention training exercises that are there, and validating one's experiences and distancing from thoughts and emotions. So these are some of the specific strategies that are used: mindfulness, metaphors, diffusion, and identification. It's very much linked to ACT also. So, coming to the efficacy, the mindfulness program has been used in OCD who refuse medication and shown clinically significant reduction in symptoms, as well as increased capacity to evoke state of mindfulness. And it was maintained; these gains were maintained for 6 months, and they did improve functionality in the refractory cases. So practical considerations are MDCT as compared to ERP is less anxiety provoking and thus may be useful in managing processes such as thought action fusion and thought suppression we commonly see in OCD. And we have to see the feasibility of using mindfulness, which has been used in this established studies. So this is how mindfulness works, like how it works. It reduces the attentional bias for threat, secondary elaborative processing, rumination, then that which is linked to the phenomenology of obsession, which in turn reduces distress and psychological activation, and we go on in the being mode instead of the doing mode. So another famous therapy in OCD is metacognitive therapy, which is again being used very increasingly. And many of the concepts and theories regarding. So what is metacognition? Basically, metacognition, for whom those who don't know, is knowing about knowing. That is an abstract aspect of cognition that controls mental processing and thinking. So I'm thinking about what I'm thinking I'm seeing. So these is what is metacognition. So basically, there is some attentional syndrome in metacognition theories that say that there is self-focused attention, repeated cognitive processes like worrying, rumination, dysfunctional threat monitoring, and which result in these symptoms that we see of anxiety and mood symptoms. So this is one model of how metacognition works. So metacognitive beliefs about the meaning and consequences of the thoughts and emotions, and metacognitive beliefs regarding the necessity to perform these rituals and the negative consequences of failure to carry on these rituals. So this TAF, TOF and TEF, So basically, this is thought action fusion, thought object fusion, thought event fusion. So the concept is that if I'm thinking that I am going to slap my friend, this might be an aggressive compulsion that a person is happening. They usually associate it with the event happening itself. That is, I am thinking means I'm doing it itself. Now, if I, go on to this quickly, this conversation that you can see on the screen, it will be very clear how the person is developing this metacognitive thoughts. Like, do you believe your thoughts about being contaminated with ancestors mean anything? So these are basically for identifying fusion belief. Then the patient says yes, especially when the specific thoughts keeps coming, I become anxious. And therapist asks, what does it mean to you when a thought keeps coming back? So the patient says that when I cannot get rid of a thought, I start to believe that the thought will warn me. Warn you for what? That what I'm thinking has actually happened, that I'm really contaminated with asbestos, and that's what frightens me. So the therapist asks, how much do you believe that having these thoughts about being contaminated means you're actually contaminated? And the patient says 100%. So there you see there is a blurring of about the actuality of the thing happening and the thought being there. So did you prevent anything to did you do anything to prevent these contaminations? So this is for identifying the behavioral responses. So the patient says yes, by washing my hands over and over again. So what is the worst that could happen if you don't do this washing of hands? That is, then I can't relax ever. So the patient has no idea when to stop. I stop when I feel that it is okay to stop. So coming to the metacognitive therapy process, so again it starts with being aware of these thought action fusions and saying beliefs about this importance of thought, developing new and flexible ways of experiencing obsessions that reduce their importance and distress cause. There are certain very specific attention training techniques that are used in metacognitive therapy to develop skills in cognitive flexibility, and detached mindfulness is also taught. Now, we're coming to the efficacy. Case series have shown that there was clinically significant changes in symptoms, and the improvements were maintained at 6 months follow-up. And group MCT has also been found to be effective in decreasing symptoms. And lastly, I would come to this another therapy which has not been very commonly used but has shown some efficacy. It's called the danger ideation reduction therapy, and it has been mostly used in case of contamination and washing and aggressive type of obsessions. So the basic concept regarding it is that people with high danger expectations regarding the likelihood and severity of a disease shows that they have increased avoidance behavior and increased washing behavior when exposed to disgusting stimuli. So these people have high expectations of the consequence of the dirt, maybe. So what happens? The therapist provides as much as factual information as possible to decrease the expectation that the harmful events such as fear of illness, disease, theft, damage will follow any failure to check. So it could reduce this therapy has usually seen that it reduces the dropout rates in conventional ERP. Basically, I will provide as much factual information to the patient as possible so that it seems very irrational that it is not possible to happen. So again, some of the components of DIRT are attention focusing, cognitive restructuring. So microbial double checking experience. These are some, experiments that the person is told to do, series of experiments that you are touching door handles and money, but not developing, any kind of disease. So corrective information, they do have certain very wrong information about so many things. Like some people, very commonly it is seen that people think they can get HIV by going to bathroom or using public urinals. So we give corrective information based on facts related to the illness and disease rates, and there are interviews, filmed interviews and videos that are shown where people who are in regular contact with contamination stimuli are doing well. And probability of a catastrophic task, like people, this is basically try to reduce the catastrophization that the person has. Now, efficacy is that it has proven to be beneficial, and especially with those with poor insight. Like I said, that people who genuinely believe that they can actually get some disease when I'm exposed, and who are non-cooperative for ERP, and it has shown to reduce severity of OCD to from severe to subclinical level, and treatment refractory adolescent as well. So coming to a short discussion of the new therapies is like only few studies have explored the efficacy of the new wave psychotherapies in OCD, and the research is largely restricted to case studies and case series and open label trials with very few RCTs and meta-analytical studies, and very small, relatively small sample size was there. Comparisons were inadequate, and inclusion of cognitive therapy in mindfulness intervention causes a doubt regarding how much the individual component of therapy is working. And in most studies, mindfulness at the nature of OCD symptoms was predominantly cognitive compulsions and not motor compulsions. So I would like to end with this, and I would also add my opinion is that it doesn't matter whether which thing is used in itself is working or not. That matters for research purpose. However, in clinical practice, we need to consider what is working for the patient. So if a component of mindfulness works for the patient, we use them. So we have to tailor make each and every therapy session for each and every patient, especially required for OCD, since everybody has varied symptoms. So thank you. Now I would like to move on to questions that might be there.
Yeah.
So
Thank you.
yeah. So any kind of questions are welcome regarding this presentation, or any doubts or anything a person wants to add to it is also welcome.
Hello. Yeah, there are a few questions in the message box. Can you please go through that?
Yeah. So screen was not visible. So was it visible?
No, it was visible. That was some technical issues.
Okay.
The first question is by Miss Swarnamina, I guess.
I can't see any questions apart from this.
No, it is there. Miss Swarnamina is asking, can you tell if yoga and meditation play a role in MBCT?
Yeah, so exactly in MBCT, mindfulness cognitive therapy, as per directly yoga and meditation is not used. Basically, it follows a model called the mindfulness model, in which they train the person using many mindfulness exercises, to be in the present moment. They train gradually. It starts with some in-session activities, like the very famous Raisin activities, and move on to mindfulness in daily living, like doing everything we are doing in our daily life, daily activities mindfully. Yoga and meditation, as far as I know, is not actually has been used in isolation for OCD itself, because generally the concept is that when we go back to the ERP and CBT model, which has been found to be more, it has been found that making the person relax during the exposure is not actually the goal. It is for the person to experience the maximum anxiety and get, habituated, or if I go by the extinct model, to learn that the anxiety will go away. But yeah, when the person is having certain other comorbid conditions, it can definitely help to calm the person.
Yeah, I guess Dr. Mashweta has answered Ms. Swarna's question. Yeah. I want to introduce to you people Mr. Nilesh Gujar. He was also my colleague. He is a psychiatric social worker. He has completed his MPhil and pursued PhD. Yeah. So he is asking, or he is in fact like suggesting us to explain the role of family in the management of OCD.
It's actually a very big topic. I haven't, gone into that. I can understand he has rightfully pointed out that family is very important in OCD management, because there is a whole research and, clinical thing called family accommodation that has been found to be in OCD. So family accommodation is basically how it's seen that family members somehow get accommodated to the symptoms of the patient. Like the patient is able to convince the person in such a way, the spouses or the family members, that they accommodate those symptoms. And so many times we see very severe cases also are not coming to the for treatment, because they have accommodated it only when it causes, like it increases and goes to a dysfunction level that is not manageable, that they come, because till then they were accommodating the symptoms. Like I know one of my patients, he would ask the husband every time after coming back home to wash the notes and keep in the wallet, wash the wallet itself, and the husband had been adjusting to all her demands, because basically what they feel is that if I don't give in, it will turn out to be like too very harmful, and they will try, so much of conflicts will be there, so it's easier for me to accommodate it. It's just few requests, so I will accommodate it to the symptoms. Mothers have seen to accommodate, especially for daughters also, they accommodate all these symptoms. And sometimes it is also considered, if it's a mild case, it's considered to be good that she is very clean, and especially when it relates to contamination obsessions and organized and all. But yeah, family. And another thing that family plays a very big role is when during therapy we have to have a co-therapist, because it's not always possible for sessions in session exposures to be the only factor that leads to improvement. There are homework exposures. Here the co-therapists, which is the family member closest to the patient, will serve a role and help in the exposure sessions and not accommodate those. We have to psychoeducate them to not accommodate. He can also, as well as add to some points, since he is like experienced in this area as a psychiatric social worker.
Yeah, Nilesh, we would like to have your inputs on this topic.
Yeah, Manu. Thank you for introducing me. Manu is my friend, and Dr. Shashi is also there. Welcome you all for the presentation. It's a good discussion that we are having. Rightly pointed out, family plays an important role. And what I wanted to say is that if we do not consider family in the intervention process, how it can affect the patient, as the rate of the disability in the patients with OCD is increasing as the family accommodation is there, and in the process we are by the process in terms of intervention, mostly we are consciously unconsciously ignore those things, that the family also need to have the intervention. They are in the distress, burden is there, express emotions is there, the family loses the support to the patient. So these things contribute to the patient's disability, as well as family members develops another mental health problems. These things are also there. So rightly pointed out. Thank you.
Yeah, I can see a number of other questions also. Like one person has asked that Harish Kumar, that when we have mild OCD symptoms, is it possible to manage only with psychotherapy, or should we go for pharmacotherapy, or both? So usually what I have seen here is that we give the choice to the person. If it's actually in the mild category, sometimes we usually give the choice to the patient, and we explicitly say that if they start medication, how long they have to take and what are the options they can go for. And I think it is either ways. They can go for psychotherapy only management as well as pharmacotherapy as well. So Dr. Manu can contribute to that.
Yeah, exactly as you said. It is up to the patient's choice, and again, depending on the severity. Now, what you have said is mild. How mild is mild for that person is subjective. According to our scale, the person may be like spending 1 or 2 hours on his obsessions or the compulsions. And if he feels that that is not bothering his routine activities, then yeah, maybe he can just go for a psychotherapy or anything like that, as he may be apprehensive about taking these pharmacological agents, thinking about the side effects or anything like that. Yeah, but if the symptoms are severe enough, then yeah, it is better to go for both together. As has been rightly pointed out right at the beginning, evidence suggests that combined therapy has a better remission of symptoms.
Yes. Another person has asked, sometimes the person will not accept that they are having OCD, and how to make them aware, especially in a place where such kind of therapists are not available. So when the person is not accepting, I would say it might be either that the person has poor insight or some kind of, I don't know the exact case, but there might be poor insight as well as psychosis bordering onto some delusional belief might be there. So we need to assess that very well, and go for a very more insight oriented approach. And initially I think medicine helps a lot in such cases, especially poor insight, and as we progress with more of psychoeducation, insight actually improves. It has been seen that since we usually rate insight along with Vibox over the period of time, many times we have seen that poor insight patients do come to the level of good insight and fair insight. So therapist is not available, so I have no answer to that particular question of availability, but and what therapy would be best for hoarding? So I would say that personally I have not seen a case of isolated only hoarding disorder. I have seen OCD patients having other symptoms with hoarding, and mostly what we need to do here is we have to go for a more of a cognitive approach, and you try to understand what are the various biases or dysfunctional thoughts the person that is underlying, or the core beliefs. We have to touch upon them and restructure them for hoarding. So another person has asked this question that I was expecting actually, that do you think the pandemic would increase the occurrence of OCD cases? Now, this is a very like a very common question that has been being discussed around the world, and people are coming up with different kind of recommendations and all. So, existing OCD patients, we are not sure whether their OCD worsens or not, because in NIMHANS also we had a particular study of where we followed up all the patients who were receiving OCD treatment from the clinic and have they worsened due to the pandemic? No, but we did not find that. New cases and we will come across. I think there has been some reports that new cases are developing, but then again we need to find out where the distinction between what is obsessional, as in there an obsessional thought of getting COVID, and whether it's within the normal limits of fear or anxiety due to the pandemic situation. So that is where we have to draw a line, I guess.
Yeah, I just want to add over here. Actually, yeah, a lot of people are coming down to clinics these days. Like, sir, our symptoms have increased. Like, we are repeatedly washing our hands and all. But these days, we have to even think like washing hands is very much necessary. Multiple washing is more helpful in preventing the transmission of these viruses. So again, we have to think about the situation before we diagnose anybody with OCD. Now the question what you have said, I just missed that question. Yeah, do you think pandemic would increase the occurrence? I won't say, because here it is more of like the repetitive behavior is some goal oriented with right purpose. It is not excessive. What we as it has been presented in the beginning, the obsession is a thought which is repetitive and it exists even after it has served the purpose or anything like that, and which is excessively more. Okay, so now this pandemic, I guess you are speaking about washing hands and all, that I will not consider them as an OCD.
Yeah, but if it is excessive in the sense that in response to a obsessive thought of getting a COVID or some kind, if it takes that obsessive quality, I guess then we can still consider. And I feel that we are yet to find out that whether the occurrence of OCD will be increased due to the pandemic. I guess we will have like in more like coming year or maybe more months, we require to see actually the prevalence, whether it has increased due to the pandemic.
Yes. The already existing cases may have aggravated. That's all we can say as of now.
Yeah.
The next question.
Tailor-made approach. So someone has recommended, Nilesh sir has recommended. So
I guess how to control and stop their disorder, OCD. That was the whole presentation, ma'am.
Yeah. So we discussed all the modalities in which we can. Maybe she's trying to ask whether it will lead to complete recovery or not. But yeah, many cases we have seen that OCD has become bare minimum. At the same time, there are cases which don't completely stop. They have to continue medications. But yeah, what we advise is that not to stop medication on themselves if the symptoms suddenly reduce, because sometimes it may increase if they suddenly stop it. And but even though it might not fully cure, there might be some obsessional thoughts that may come, but we have seen that compulsions do go away completely many times. And even if they don't, the main goal, I think, as we always say, is whether the person can function adequately in the social and occupational area.
Yeah, totally agree with that.
Yeah.
Nilesh wants to add something. There is a study which says we are just pointing out intentionally to the OCD symptoms, but in reality, it is same for a person with OCD during pandemic. Nilesh, I guess you can put this out for others by yourself. It would be really helpful.
Okay, thank you, Manu. Actually, what has been seen that so there are as the pandemic came, there are scholars, researchers who came forward and who started doing these studies that, and they found it is reality that the rate of mental health or the occurrence of mental health problems has been increased, and there are so many psychosocial factors attached to it. And there are studies which says that how the now the pandemic has asked all of us to be to maintain hygiene, to maintain physical distancing, wash hands. So how it has impacted on the people who are already having OCD. So they found that so the people with OCD, they are for them it is the same life which they are living. Okay, so there is a little bit difference in the previously having compulsions of the hand wash or the other things, but it is not a significant increase which we should pointing out that the OCD has been increased because of the pandemic. But it is the same for the people. They do not find it as because of the pandemic they are having the increased ideas or compulsive thoughts or sorry obsessive thoughts for the dirt and contemplation or the other things, but for them it is the same throughout. There is no change, but other mental
Yeah,
problems
I would completely agree with that because in our follow-up of around 250 to 300 patients who had visited the OCD clinic over last year, we did a follow-up of the COVID situation and we saw that most of them, hardly very few people had actually worsened because yeah, one two patients do come to us saying the worsening, but when we see at a large number of the all of them, we see that since OCD, we are hypothesizing that since OCD is a very specific to the obsessions and compulsions are very specific processes underlying, like mainly very specific to the patient itself, to touching doorknobs, to aggressive thoughts that come. So it generally has not generalized to the COVID situation that much. They are not that concerned about the COVID contamination, but their contamination goes back to the dirt and contamination related theme that was important to them before as well.
yeah, right.
Yeah. Uh, like Kavyashri ma'am, can you give some inputs to the students, to us, to everyone?
Yes, sir. Hello.
Hello, ma'am. Yes, ma'am,
Yeah.
please.
I was just listening to the presentation. It was a very wonderful presentation. As such, I don't have anything to give as an input, sir, because we work at a counseling level. I'm a counselor. So, what I do is whoever I get here having complaints of OCD, I screen them and send them to a clinical psychologist. So, that is what we have been doing. But what I do is like many, we do have online counseling centers. Many of them have come up with symptoms of OCD. And what I observe is like it has increased recently after this pandemic has begun. For me, the kind of cases I have been getting. So I directly refer them to a clinical psychologist. I can just say that.
Yeah. Thank you very much, ma'am. Yeah. Any other questions? Guess we can wait for a couple of minutes before we wind up to see if at all anybody is having any last minute questions or doubts.
Thank you, Mahasweta, for such a nice presentation.
Thank you.
This is Dr. Shashi online.
Okay.
I was in clinic actually, that's why I was like, I was listening. It was a wonderful presentation. Third wave therapy and all. Na? I would
Thank
really
you.
ask you to take one session for this DBT or all. That would be wonderful. Mindfulness
Okay.
based, yeah.
Yeah.
Yeah,
Sure.
yeah, yeah. Yeah. So,
Sir, I just have one point to add. Like ma'am said, it was very, whatever she included in the psychoeducation part. There are many students who are participant here and social workers also. Like how ma'am said, if we can psychoeducate